Welcome to Ask the IncrelEXPERTs. In this video, Dr. Ron Rosenfeld will answer the question, how does one screen and diagnose severe primary IGF-1 deficiency, or SPIGFD? Dr. Rosenfeld is a professor and chair of pediatrics emeritus at Oregon Health and Science University and a professor of pediatrics emeritus at Stanford University.
Today we'll be discussing how to screen for and diagnose severe primary IGF deficiency. The first step to screening for severe primary IGFD is recognizing the clinical characteristics, such as short stature. This profound postnatal growth failure should prompt a general assessment, which may include a review of the patient's growth history and medical history, physical examination, or general laboratory tests. If the general assessment rules out chronic illness and other causes of short stature, an investigation may then be conducted to assess the growth hormone IGF-1 axis. At this point, you would most likely perform growth hormone stimulation tests. If the growth hormone levels come back low, you've diagnosed growth hormone deficiency. If, on the other hand, the growth hormone levels are normal or elevated, then you may measure IGF-1 levels to see if they are normal. Low IGF-1 levels are indicative of a primary IGF deficiency or severe primary IGF deficiency diagnosis, with the former requiring an IGF-1 standard deviation score of less than -2 but greater than -3, and the latter requiring an IGF-1 standard deviation score of less than or equal to -3. So to recap, screening for severe primary IGF deficiency starts with recognition of profound postnatal growth failure and excluding secondary causes of IGF-1 deficiency. Next, we perform growth hormone stimulation tests. When these tests reveal growth hormone to be normal or elevated, we measure IGF-1 levels. If IGF-1 levels are low, then we can confirm a diagnosis of primary IGF deficiency or severe primary IGF deficiency. When it comes to optimizing growth outcomes for patients with severe primary IGF deficiency, knowing how to properly screen for and diagnose the condition is critical. When you diagnose severe primary IGF deficiency as early as possible, you can help children reach their full growth potential.
Indication. IncrelEX mecasermin is indicated for the treatment of growth failure in pediatric patients aged 2 years and older with severe primary IGF-1 deficiency IGFD, or with hormone GH gene deletion who have developed neutralizing antibodies to GH. Limitations of use. IncrelEX is not a substitute to GH for approved GH indications. IncrelEX is not indicated for use in patients with secondary forms of IGFD, such as GH deficiency, malnutrition, hypothyroidism, or chronic treatment with pharmacologic doses of anti-inflammatory steroids. Severe primary IGF-1 deficiency IGFD is defined by height standard deviation score -3.0 and basal IGF-1 standard deviation score -3.0 and normal or elevated GH. Important safety information. Contraindications. Hypersensitivity to mecasermin rhIGF-1, any of the inactive ingredients in IncrelEX, or who have experienced a severe hypersensitivity to IncrelEX. Allergic reactions have been reported, including anaphylaxis requiring hospitalization. Closed epiphyses. Malignant neoplasia in pediatric patients with malignant neoplasia or a history of malignancy. Warnings and precautions. Hypoglycemia. IncrelEX should be administered 20 minutes before or after a meal or snack and should not be administered when the meal or snack is omitted. Glucose monitoring and IncrelEX dose titration are recommended until a well-tolerated dose is established and is medically indicated. Intracranial hypertension. Fundoscopic examination is recommended at the initiation of and periodically during the course of therapy. Lymphoid tissue hypertrophy. Patients should have periodic examinations to rule out potential complications. Slipped capital femoral epiphysis. Slipped capital femoral epiphysis may lead to osteonecrosis. Cases of slipped capital femoral epiphysis with or without osteonecrosis have been reported in pediatric patients receiving products indicated to treat growth failure and slash or short stature, including IncrelEX. Carefully evaluate any pediatric patient with the onset of a limb or hip/knee pain during IncrelEX therapy. Progression of scoliosis. Patients with a history of scoliosis treated with IncrelEX should be monitored. Malignant neoplasia. There have been post-marketing reports of malignant neoplasia in pediatric patients who received treatment with IncrelEX. It is unknown whether there is any relationship between IncrelEX therapy and new occurrences of neoplasia. The tumors were observed more frequently in patients who received IncrelEX at higher than recommended doses or at doses that produced serum IGF-1 levels above the normal reference ranges for age and sex. Monitor all patients receiving IncrelEX carefully for development of neoplasms. If malignant neoplasia develops, discontinue IncrelEX treatment. Risk of serious adverse reactions in infants due to benzyl alcohol preserved solution. Serious and fatal adverse reactions, including gasping syndrome, can occur in neonates and infants treated with benzyl alcohol preserved drugs. Use of IncrelEX in infants is not recommended. Adverse reactions. Common adverse reactions include hypoglycemia, local and systemic hypersensitivity, and tonsillar hypertrophy. To report a suspected adverse event related to IncrelEX, contact Eton Pharmaceuticals, Inc. at 1-855-224-0233 or the U.S. Food and Drug Administration FDA at www.fda.gov/safety/medwatch or call 1-800-FDA-1088. Please see full prescribing information for more information.
On behalf of all the IncrelEXPERTs, thanks for watching.